Hello, I'm Dr. Dhanya Dharmapalan. I'm a consultant in pediatric infectious diseases at Apollo Hospitals, Navi Mumbai, as well as a visiting consultant in infectious diseases at Yevlis Hospital for Children in Vashi, Navi Mumbai. Now today let us discuss about infections in critically ill children. And critically ill children, as we are all aware, are very prone for infections because of the disruption in their mucosa or the physical barriers, or due to ventilation-associated lung injury. Also, infection itself is the commonest cause for admissions in intensive care units. So let us see how we can approach such children and manage them efficiently with good antibiotics diversion. So on suspicion of a bacterial infection in critically ill children, first of all, since time is of essence, we need to start antibiotics as early as possible. But even then, you need to send the appropriate cultures so you are able to adjust or modify the antibiotics accordingly. Now, when you are suspecting a bacterial infection, the following questions should come to the mind to decide the empirical antibiotic choice. First of all, what is the suspected organism in that patient? Like for example, if the child has severe lower respiratory tract infection, one would think of covering the usual organisms if it is community acquired. So like Streptococcus pneumoniae, Staphylococcus aureus, H. influenza B. So the antibiotic must cover these organisms. If it's a child with severe urinary tract infection, then one should consider covering most of the gram-negative organisms. If the child has road traffic accident and has come, so it's a case of polytrauma where you might even consider covering for anaerobes. Secondly, what is the site of infection? For example, if the child has meningitis, the antibiotic used should be able to cross the blood-brain barrier. For example, ceftriaxone, but remember that beta-lactam inhibitors will not cross the blood-brain barrier, so you should avoid using them. Third is there host comorbidity? That is, if there is a renal compromise, you would like to adjust the antibiotics as per the renal dose, or you would like to avoid nephrotoxic drugs like aminoglycosides or vancomycin. Then fourth is the severity of illness. So if the child has presented in shock, then you do not have time to escalate, in the sense that because a discordant empirical choice might in fact worsen the morbidity or increase the chance of mortality. So you can then we go for very high-end antibiotics in such situations like even carbapenems or vancomycin. Then lastly is a upfront cover for resistant bugs, like say MRSA. There has been very recent hospitalizations. Then the other important step in critically ill children is source control, whether it is a case of appendicitis or whether there is CLABSI suspected. Now you can also optimize antibiotics in these critically ill children, like for example by using principle of time-dependent killing. You can give continuous or prolonged infusions of beta-lactam antibiotics. Then one should also remember to modify one should also remember to be alert of drug interactions. So because these children are on so many drugs, like for example anti-epileptic drugs, so there can be potential drug interactions which one should be aware of. And definitely loading doses need to be given in critically ill children so that you are able to reach the therapeutic desired level sooner, and also cover for resistant organisms. So very important is during the course of stay in the ICU, as the cultures come, one should de-escalate or escalate as per the culture reports. And one should understand the interpretation of cultures as well and not treat possible colonizers. Infection control is also a cornerstone of management in ICU, and one should try to prevent secondary bacterial infections which can occur in ICU.
And there are certain other types of infections which are more prevalent in critically ill children. So let us actually go into the battlefield, that is the PICU, and discuss these kind of infections. Hi Dr. Mona Lisa. Hi Dr. Rahul Verma. Dr. Rahul is our pediatric intensivist at Apollo Hospitals, Navi Mumbai, and I have come to discuss with you hospital-acquired infections. So in your daily round in PIC, when do you usually suspect nosocomial?
Dr. Dhanya, this is a very important topic. So whenever there is a new onset of fever, chills, altered mental station or hypotension in a pediatric patient in the ICU, suggestive of bacteremia, most likely due to clepsy, or there is productive or non-productive cough with shortness of breath with a chest pain, which may be suggestive of hospital-acquired pneumonia or ventilator-acquired pneumonia, or there is abdominal pain or loose motion suggestive of Clostridium difficile diarrhea, or there is symptoms like flank pain, suprapubic pain, dysuria suggestive of catheter-associated urinary tract infection, or there is signs of suppuration at the site of indwelling catheters or surgical site, which is suggestive of skin and soft tissue infection or surgical site infection. So thorough and serial examination is the key. We have to have a high degree of suspicion if there is an indwelling catheter. Daily examination of the site, setting and location of the catheter devices is important. If a central line was placed hastily in an emergency situation, you have to replace it or reevaluate its need within 24 to 48 hours. The site of skin injury, if any, and surgical site has to be watched daily for any signs of evolving infection.
So let us start with CLABSI, that is catheter-associated bloodstream infections. So when do you suspect CLABSI?
So CLABSI is suspected if there is a presence of an indwelling central line or arterial catheter in the preceding 48 hours of you being grown a positive blood culture. The central line should be the compelling source of infection and no other possible etiology should be there. The common organisms which are associated with the CLABSI are Staphylococcus aureus, coagulase negative staphylococci, Enterobacteriaceae such as E. coli, Klebsiella, Acinetobacter, Pseudomonas species, and common yeast like Candida. The reasons for developing CLABSI can be divided into extraluminal causes and intraluminal causes. Extraluminal causes normally come as a source within the first 7 days of line insertion. The intraluminal causes are normally seen after more than 7 days of line insertion. Rarely the source of CLABSI can be a contaminated catheter at the time of storage or during manufacturing. So, Dr. Dhanya, how do you manage a CLABSI now?
For management, what is very important is the correct diagnosis, and very important is to send a set of blood cultures, one from the catheter and one from the peripheral line. So the central, and very important again is to label them correctly, which one is from the peripheral line, which one is from the central line. Once you suspect CLABSI, the antibiotic should be started ideally within 1 hour of suspicion. Now, in the lab, how it is confirmed is if the culture from the central catheter is showing the same bacteria as that from the peripheral line with the same antibiogram, and if the colony count, that single bacteria, is at least 3-fold higher from the catheter culture in comparison to the peripheral, as well as if the time of positivity of the central line is earlier, that is less than 2 hours from the growth of the peripheral line culture, then we can confirm it as catheter-associated bloodstream infection. And if generally broad spectrum antibiotics are started, so if there is hemodynamic instability in that patient, I mean we are considering a complicated CLABSI, or there are signs of endovascular infection or a metastatic infection, it is recommended to remove the catheter as early as possible. If the catheter cannot be removed for any reason, then the duration of antibiotic is longer, at least for 2 weeks. If there is source control done, that is the catheter is removed, then the duration is shorter. Like in some cases of uncomplicated CLABSI, we can even give up to 7 days of duration.
Very important point, Dr. Dhanya. Thank you.
So let us talk about prevention now of such infections. And I'm just thinking of air flight checklist that even competent pilots carry out on day-to-day basis. They have these checklists. So similarly, however competent the ICU team is, the nurses are, it's extremely important to carry out these checklists.
Very important point, Dr. Dhanya. So like this checklist in medical parlance is known as a bundle. So we have various bundles like CLABSI bundle, VAP bundle and COTI bundle. So what is a bundle? Bundle is a set of written points which have to be followed by all the medical team members during the insertion of a catheter or device and while having a daily monitoring of that device. So the most important point is hand hygiene. If you have followed a proper hand hygiene during the insertion of the catheter, any catheter has to be a sterile procedure. Daily assessment of the site of catheter insertion and the signs of evolving infection at that site, and you document it like this in each shift by our paramedics, then we are able to prevent, or if it happens, detect very early signs of CLABSI. So this is the CLABSI checklist that we follow in our institution.
Okay. So let us now move on to hospital-acquired pneumonias or ventilator-associated pneumonia.
So any lower respiratory tract infection that appears during or after hospitalization of a patient which was not incubating at the time of admission is normally known as hospital-acquired pneumonia. The diagnostic criteria are presence of fever, cough, either productive or non-productive, or purulent sputum, new findings on the chest X-ray, and a microbiological confirmation on a gram stain or on a culture, then it is known as hospital-acquired pneumonia. So coming to ventilator-associated pneumonia. Hospital-acquired pneumonia in any patient who is on mechanical ventilatory support for more than 48 hours is known as ventilator-associated pneumonia. The indication is a deterioration in the respiratory findings such as new onset X-ray findings or increased oxygen requirement or deteriorating gas exchange with increased need of ventilatory support. The criteria are temperature, leukocytosis or leukopenia or purulent secretions. Any two of these three have to be present to label it as ventilator-associated pneumonia. Dr. Dhanya, how do you treat ventilator-associated pneumonia?
Again, the diagnosis is important. So the best ideal way actually is invasive through minibal or bal, and if you have a colony count of 10⁶ or more, then you can confirm it as VAP in such patients. And generally the causative organisms in these conditions are multi-drug resistant bugs, gram-negative like E. coli, Klebsiella, Pseudomonas or MRSA. So the antibiotic regimen also should cover these bacteria. And the duration of the treatment can be around at least minimum 7 days and or as clinically indicated.
Up to 14 days, correctly put. So similar for a CLABSI, we also have a VAP bundle in which there are points to be checked at the time of endotracheal intubation, during ventilatory support therapy and daily assessment by a nurse, such as hand hygiene, elevation on a bed by 35 to 40 degrees, sterile precaution while doing catheter-associated urinary tract infection or COTI with indwelling urethral catheterization. If there is a presence of signs and symptoms compatible with urinary tract infection with the colony count of more than 10⁻³ of a one or more bacteriological species in a single catheterized urine sample, or the colony count more than 10⁵, if there is no signs and symptoms of UTI, or even if the catheter has been removed up to 48 hours of removal of urinary catheter, if the colony count is more than 10⁻³ with symptoms, it is still considered as COTI, and the presence of only pyuria is not diagnostic of COTI. Any more points you'd like to add, Dr. Dhanya?
Yes, and urine sample in such patients should be collected from the sampling port and not from the urinary bag, because that can give errors of contamination which would be treated as true pathogen. So please remember that. And the duration of antibiotic should be minimum 7 days. To, of course, in case there is associated bacteria, it should be longer, about 10 to 14 days.
Yeah. So again, we have a CORTI bundle to prevent the incidence of CORTI happening in our critical care setting. It has a checklist and a time of insertion and daily monitoring. Against the right precautions has to be followed while inserting a urinary catheter. Hand hygiene is very important. The bag has to be at a lower level. Frequent emptying of the bag has to happen, and we have to be watchful for any signs of urinary tract infection on our daily rounds.
And very importantly, I think in every round we should discuss really should the patient still continue to be on. To summarize, Rahul.
Yes, so prevention is always better than cure. Hand hygiene is very, very important. Antibiotic stewardship is the cornerstone to prevent the development of MDR organisms. Strict asepsis has to be followed during the procedures and while daily use of the indwelling catheters. Use of checklist or the care bundles is an additional preventive measure. Safe environment, good ventilation, following hospital waste policies, and education of our healthcare workers, vaccination and surveillance for hospital-acquired infections go a long way in preventing. Lastly, we should not forget the Hippocratic principle of primum non nocere, first do no harm.